Okay, so why don't we go ahead and get started here? So good evening and happy Wednesday. My name is Kyle Sebastian and I am the Community Engagement Manager here at NAMI, Tennessee. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. Today, NAMI represents an alliance of 48 state organizations and over 600 local affiliate chapters. As one of NAMI's state organizations, NAMI Tennessee is dedicated to improving quality of life for individuals with mental illness, their families, and their communities in Tennessee. To help improve outcomes for all Tennesseans with mental health conditions, we want to welcome you to the first webinar in our series for BB Moore Campbell Minority Mental Health Awareness Month, also known as BIPOC Mental Health Month. Through these webinars, we are supporting efforts to improve access to mental health treatment, services, and support for racial, ethnic, and sexual minority populations, including BIPOC, Black, Indigenous, people of color, LGBTQ+, lesbian, gay, bisexual, transgender, and queer questioning, and immigrant communities in the state of Tennessee. And now for some more background. BB Moore Campbell was an author, advocate, national spokesperson, and co-founder of NAMI Urban Los Angeles, who passed away in November 2006. Before her passing, Campbell advocated for creating mental health awareness and eliminating stigma among diverse communities. BB Moore Campbell National Minority Mental Health Awareness Month was then established in 2008 by the U.S. House of Representatives. And so for tonight's presentation, we are so excited to be joined by psychiatrist Dr. Howard Burley, Chief Clinical Director of the Tennessee Department of Mental Health and Substance Abuse Services. Dr. Burley will discuss the role that education, early intervention, technology, access to care, the use of best practices, and a focus on patient-centered outcomes can play to address our societal need to improve outcomes for BIPOC, LGBTQ+, immigrant, and other minority communities. But before we continue, I just want to help set the table for our presentation today. First, this webinar is being recorded and simultaneously streamed to those who registered on Zoom, as well as individuals joining us via Facebook Live. Second, if at any point you have a question for Dr. Burley, please type your questions into the Q&A/comment boxes on your respective platform. We will address questions asked on Zoom first, followed by any comments from the Facebook Live. We will leave time at the end of Dr. Burley's presentation to address as many audience questions as we can. And with all of that out of the way, I am going to go ahead and pass it off to Dr. Burley to formally introduce himself and today's presentation. Dr. Burley, thank you so much for joining us today.
Okay, thank you, Cal. Hello, everyone. My name is Howard Burley, Jr., and I'm the Chief Clinical Officer with the Tennessee Department of Mental Health and Substance Abuse Services. It is my pleasure to be here with you this evening. And I look forward to sharing with you some of the objectives of our presentation. Cal, let's take a look at those. And we want to get a couple things accomplished today. We want to talk about the factors that lead to poor mental health outcome amongst minorities. And then what we want to do is talk about the role that education, early intervention, technology, access to care, best practices, patient-centered outcomes play in addressing the mental health needs amongst minorities. For years, there's been discussion of disparities and trying to deal with outcomes. And hopefully, when we finish this presentation, we'll be able to provide some hope for individuals that these issues can be addressed. Before I get started on the presentation, I did want to say a couple things about BB Moore Campbell. As Cal was pointing out, she was many things, but one of the things that I found her to be most important was a teacher. She was able to educate communities. She was able to talk to different organizations, and most importantly, she was able to talk to lawmakers about the need to address the disparities between communities of color. In 2005, BB Moore Campbell recognized the need to have a month devoted solely to minority mental health awareness. And it was unfortunate that she passed away in 2006. But friends and other individuals that she motivated carried on her work. And finally, in 2008, the House of Representatives recognized her work with B.B. Moore Campbell Minority Mental Health Awareness Month. And I just wanted to point that out because it shows the power that a single individual has to motivate their community to implement change. So I know it's frustrating sometimes dealing with mental health issues and accessing services, but when I look at someone like B.B. Moore Campbell, I know it can be done. All right, let's talk about some things in particular. One of the things that I thought was interesting in that it shows how much things have changed and then how much things have stayed the same. What I have here is a graph, and it looks at mental health services that are received by race. And we made the point that B.B. Moore Campbell month was recognized back in 2008. So I thought it would be a good idea to compare what's happening in 2008 with the most recent statistics we have in 2019. And if you look at these, if you start off looking at individuals that identify with two or more races, identify as being white, American Indian, Black or African American, Hispanic, Latino, Native Islanders, what we see is that there's been very little change in the amount of services that those populations have received. And it's really interesting if you look at it, that you see that while they may have moved 1 or 2%, it's really that same 1 or 2% it's always been for those groups. And the other thing that that adds to the frustration of this sometimes is if you look at it, the striped areas on the graph represent unmet need. So while we've shown some improvement over the years in terms of access to service, that's been countered by the lack of the unmet need that continues to be the issue going forward. Kyle, let's take a look at the next one. One of the things that is always a question is when you say minority, when we're talking about minority mental health awareness, just who are we talking about? And we're referring to race, ethnicity, culture, gender, sexual orientation, immigrants, refugees, religious groups. The thing that's happened over the years was when B.B. Moore Campbell started off, and we were talking about the word minority, we were basically talking Black, Hispanic, but that tent has gotten huge over the years. There are so many groups that have been added that are not getting access to the services that they need. You know, back in 2008, we weren't talking about Black indigenous people of color. We weren't talking about LGBTQ+. We weren't talking about DACA. We weren't talking about documented versus undocumented immigrants. All these things have changed, and the thing that has stayed the same is as the minority groups have increased, the access to care has still lagged behind. Next slide, Cal. I just want to take this opportunity just to point out some of the basic facts about mental health and the prevalence of mental health illnesses in the country. I know from one of the previous Minority Mental Health Month, one of the themes was "You're Not Alone." And I think that's one of the things that we need to keep emphasizing, that at the top of the graph, we see that 1 in 5 US adults experience some type of mental illness, that 1 in 25 experience a serious mental illness, and that 17% of our youth experience some type of mental health disorder. And while when we look at the 12-month prevalence rates for the different minority groups that we previously discussed, while we recognize that for the LGBTQ group, the presence of any mental illness is the highest. Statistically, it has been close for all groups, and that the focus on need to increase access to service, reduce stigma, all are very important in terms of addressing the outcomes that we want to reach. I just wanted to point out in the graph to the left, just by diagnostic groups, just what some of the common mental health issues faced by adults are in the United States, with depression and anxiety disorders being the highest. You know, at the end of the presentation, I'm going to say a few words about COVID. But I think that one of the things that I just wanted to mention from the beginning is that the impact of COVID has just led to increase in the isolation, anxiety, depression that many of these minority groups that we've spoken about have already struggled with, and really increased the need for services. And hopefully that increased need is going to generate some action that may lead to some long-term improvements in the delivery of behavioral health services. Okay, Kyle, next slide. And this is just a basic slide. It just once again points out the prevalence of any mental illness. I know sometimes we get bogged down into whether a person is depressed, anxious, whether they're suffering from bipolar disorder, schizophrenia. But for the purpose of this slide, we just wanted to see just what is the rate of any mental illness amongst the different groups in the country. And I think what you see is that statistically, the percentages are relatively close. Once again, the highest prevalence is amongst those that identify as being in two or more different racial groups. Okay, next slide. And just talking about the special populations, I just wanted to bring out this slide. It talks a little bit about the percentage of LGBT individuals that experience difficulty with a mental illness. I think the thing that stood out to me most is that that almost 1/3 of these individuals experience some type of defined mental health issue, which is 60% more than the heterosexual population. And just a few of the important statistics to point out is transgender people attempt suicide 9 times more than the entire US population. LGBTQ adults, 50% more likely to develop an alcohol or a substance use disorder, and almost 3 times likely to develop some other type of substance use disorder. The thing that we really want to demonstrate is that the need for services are there, and that the goal needs to figure out how to increase services to all these various populations in order to improve their overall outcome from the stresses that they deal with. Next slide, Kyle. One of the things that comes up really often is when we talk about outcomes. I know I see that listed all the time. How are we going to improve outcomes? But they never really define what that outcome is. We talk about the minority groups have poor outcomes. So just what are we talking about? And there are really some simple things that really shouldn't be as impacted as they are, because the most important thing that we're looking for is the quality of life a person has. We're looking for really the ability to have just some of the basic things that any person should be able to access. And when we look at measuring the outcomes, some of the important ones I have listed here are the quality of life, the ability to have a job, the ability to receive treatment and care without having to go to an emergency room to get it, or not having to go inpatient to a psychiatric hospital to get treatment. One of the things that I see very often, we did a lot with the state psychiatric hospitals in Tennessee, And one of the things that is most frustrating is to see people who have to come and be hospitalized simply because they can't access their prescription, or they can't find a doctor to prescribe the medications that they already have had previously, that they just need to see somebody to get a prescription. And then what happens is they get off meds, they wind up being hospitalized, and once again, this just leads to a poor outcome for them. Because if, say, for example, if you're working and suddenly you've worked hard to get yourself into a recovery period where you're able to maintain a job and employment, and then you can't access your medications, and that puts your whole job at risk because you're going to be off work either because of your illness or being hospitalized. So this has, once again, feeds back into impacting that overall quality of life. And the other thing that we talk about too is important in terms of outcomes are morbidity and mortality, and especially mortality that might be related to issues of suicide and self-injury. So just what are the barriers? What are the things that keep us from having the positive outcomes that we want our patients to reach? The thing that has been present ever since 2008 and even before then is the role of stigma. Stigma is probably the number one barrier to successful outcomes for people with mental health issues. And the difficult thing about stigma is it can be the way that people look at the individual, but it can also be the way the individual views themselves. Because if a person is not educated about their illness, they start feeling bad about themselves. It results in them not wanting to talk about it, not wanting to go out and seek treatment. And this just leads to the progression of whatever mental health issue they might be struggling with. As we talk about access to healthcare these days, one of the most important things is health insurance. You know, there's a struggle now even going on for those who have health insurance to access proper care. I have friends who've contacted me because a member of their family is working, they have health insurance, but they can't find a provider. So even the insured are struggling. And then when you pair those with individuals who don't have access to health insurance, this becomes a huge barrier in terms of getting proper treatment and having a successful outcome with any of their mental health issues. We struggle too with language barriers. We've talked about the different immigrant groups coming into the state. We talk about trying to find culturally competent providers, and language barriers continue to be an issue that can impact the quality of the health services that patients are able to access. And finally, too, we talk too about the diversity amongst providers. You know, for many people, they need somebody that understands their culture, their history. One of the things that we've talked about in the past in discussions is that for many different cultural groups, the way that anxiety and depression manifest themselves may frequently not be in a complaint of either I'm depressed or I'm anxious. A lot of times that comes out in a physical complaint, or in the sense of my chest hurts, you know, when they're having a panic attack, or they have a lack of energy when they're experiencing issues with depression. So it's important that as we try to address our ability to have successful outcomes, that we find not only a diverse group of providers, but those that can be culturally sensitive to their healthcare needs. And discrimination is a whole nother issue in the treatment setting, especially for some of the populations that we recently started talking about in terms of access to care. And then finally, one of the barriers is poor quality of care. It is sometimes difficult to find a provider that provides a full array of services. You know, a lot of times you'll encounter a provider that the only thing they want to do is give you a pill, you know, that they don't want to sit down and provide you with the different types of therapy that we know can be effective in addressing multiple mental health conditions. And then when we do find therapists, that they are able to engage the patient and provide them with the cultural support that they need to help process the information and talk about the things that they need to in order to get the proper treatment for their particular problem. So during Minority Mental Health Month, we identified these things that we need to do. And this is the opportunity to take a single month and focus on in targeting those issues which we feel are so important. And I've got them listed here. And the ones that have become the standard ones in terms of importance to address are awareness, stigma, access to quality services, the role of discrimination, and also improving the education surrounding mental health issues in general. And so we'll talk a little bit about awareness first, Kyle. I think that's on our first slide. You know, it's difficult sometimes to get family and friends to understand about different mental health conditions. And it's also hard sometimes for the patient to come out and talk about whatever issue they might be addressing. But that's where it begins, is that if we don't communicate with each other, we can't become aware of what's going on with someone, and we can't become aware of what type of services are available. You know, we talked about stigma before, and a lot of times people become concerned about the way other people are going to look at them or view them. And this is where stigma really becomes entrenched. But what we find is that if people are able to open up and share that experience, it can be a lifeline to others. You know, way back in the beginning, we showed that slide talking about you're not alone, because the way that other people learn that they're not alone is by somebody else opening up and sharing their personal experience with them. And I'll tell you an experience that I had one time. This is the best example of this. I worked in the substance abuse field. And before we became much more educated about the prevalence of co-occurring disorders, I worked with an organization where that there was a significant degree, it was primarily a substance abuse abusing population, but there was a significant degree of stigma about taking medications. And in the facility where I worked, there was a lot of hesitancy. Just like we see now about vaccines, there was hesitancy back then about people being on antidepressant medications and treating co-occurring illnesses. And one of the things that was most impactful in that setting was that we had a meeting, sort of a community meeting, to discuss the issue. And during that meeting, several people stood up and talked about their own personal struggles with both substance abuse and mental illness. And it was an eye-opening experience for the other people in the room, is that these people who they had known for years, who had been afraid to come out and talk about their struggles with depression, anxiety, post-traumatic stress disorder, when they talked about how they had sought treatment, it carried over into the other group. and people became more educated and aware. And it changed the way that the whole organization looked at people with co-occurring illnesses. And that's the same thing that we see now in terms of addressing stigma. As long as people feel that they are going to be looked at differently, it blocks their decision to go and seek proper help and treatment. We talk about using kind language. And in kind language, I mean, to me, that's discussing mental health issues just like you would any physical health issue. You know, we don't identify diabetics by their disorder. You know, we don't say, oh, there goes a hypertensive guy over there. But we tend to do that with people with mental illness. And that's just because people aren't really educated just how similar both mental health issues are with physical health issues. And if you struggle with any type of mental health disorder, the most important thing is to educate yourself about it and to try to help your family become educated about it. Because this goes into the whole part about early intervention. If you know yourself and you know your behaviors and your family knows you, then you're working as a team, as a unit. When things happen that you're having some difficulty or that you need some extra little piece of treatment to help. And then the other things that we need to do just on a community level, mental health screening events. Depression, as we saw on the slide, is quite prominent in the country. It's even been more prominent than ever since COVID-19. All mental health condition percentages are high. And it's important now that we identify these conditions early and get people proper help. And also the other things that you can do are to volunteer. You can also encourage people to take care of themselves physically. And then there's no replacement for the use of social media now in terms of being able to share, discuss, and look for access to proper support, and also increase awareness about mental health issues. All right, Kyle. The biggest struggle I see in terms of mental health outcomes these days is getting to the service. You know, it is, while the percentages of white versus minority groups is quite similar, the access to services is quite different. And we've got to become more creative in terms of bringing these services to the people. You know, there is a mental health shortage already happening in the country. We have a shortage of psychiatrists, social workers, psychologists, all mental health professionals across the board. And that has a trickle-down effect. So if you are already having difficult accessing services, it's going to become even greater now. So that's going to require more creativity in terms of getting the proper mental health services to the people that need those. And well, I think one of the things that we've seen that has been a great idea in addressing this need is the integration of primary care and behavioral health clinics. In terms of people being able to access services, if you already are going to see your primary care doctor about any medical condition you have, be it diabetes, hypertension, anything like that, if you can embed a behavioral health person in that office, then that is a good way to access treatment. Also, if you access a behavioral health person who can work with your primary care physician or prescriber about medications, that will cut down on the need of having to try to find a psychiatrist. What you can do is in one single appointment, get both of your services met. I know we were doing this years ago. I was talking to Cal before we got started about working in a homeless clinic. And one of the things that we recognized early was that we had difficulty getting people back in for appointments. And if we got a hold of them, we needed to treat them when we had them, and when we had our hands on them. So one of the things that we did was we habitated our psychiatrists and medical personnel. So when you came in and got your checkup for your blood pressure, you could also see a social worker about your mental health issues. If you needed a prescription, there was a psychiatrist on site. So in a one-stop shop, people were able to access services. We were able to maintain people on medications, and we were able to take care of their primary healthcare issues, which always ties back into your mental health. There's always the mingling of health and mental health in terms of the whole person. In terms of accessing mental health services, I know one of the things that we also have to do is start supplementing the workforce. And by that, I mean, look at other types of providers. I was looking at some statistics the other day, and one of the medical groups or prescribing groups that people commonly use these days are physician assistants. And I was shocked to learn that in the United States, that only less than 2% of the physician assistants work with any type of mental health issues. This is a whole group of people who are capable of providing quality medical care, who could also be trained in mental health issues and really be a valuable addition to the mental health workforce. It's really a group of providers that's been untapped. And since many of these providers are very diverse in the communities that they come from, it's a way of addressing cultural competency too. It also, since they're so diverse, it also can help with language barriers. But we have to start thinking more out of the box in terms of getting services to people. Because one of the things that's happening is we're not going to have a huge increase in the number of providers available in our communities. Another way of improving access to service is delivering services to where people live. One of the things that I've seen in the pandemic, when they were talking about vaccine rollouts, they started talking about going to where people are. And that's the same thing that we've been needing to do for people with mental health issues that don't have access. If we can do more of clinics in communities of need, and one of the things too that I've seen done in the past is the presence of mobile clinics. If we can have mobile providers go out to people in their communities and increase their access to service, because one of the things that is a common barrier in most of the populations that we were talking about is access to transportation and the ability to get out from their community. One of the things that keeps people trapped is that they can't get across town to go to another provider, and that there's nobody in their community accessible to them. So the use of mobile transportation, mobile providers, taking care to people is another way of increasing access to health. And we typically talk about money when it comes to these issues. And one of the ways that we can work on increasing the mental health providers is to look at student loan repayment. We've been talking about student loan forgiveness. I know it's a big issue right now. People are coming out owing tremendous amounts of money. And as we talk about their quality of life, as they struggle to pay back all this money and establish themselves, if we could help them by helping us provide access to people in need. So I think student loan repayment is another way. We also have to work with insurance companies about finally establishing some type of parity in terms of reimbursement rates. for mental health providers. When we talk about one of the issues of disparity is that the reimbursement for mental health providers is very often substandard to that for medical providers. And finally, in terms of improving access, we've got to become more politically active. I go back to B.B. Moore Campbell and the power of one, because talking to your lawmakers, to your legislators, these are the people who control the purse strings and can actually have some impact on the system. You know, I guess I've seen so much from the pandemic in terms of things that we have said couldn't happen, that all of a sudden are happening. And there's no greater example of that than what I see in the use of video conferencing. For years, we've talked about telepsychiatry, telemedicine, and there's always been some barrier. It's been, well, you can't get reimbursed for two people on both ends, or it's not the same as a face-to-face visit. But when we got faced with the fact that everybody was sequestered in their home, people couldn't access services, then suddenly a lot of state governments put in waivers that took down the barriers to video conferencing. And suddenly we had a link to providers that were culturally competent, spoke the same language, that could see people in their own homes, and take down some of the huge barriers that prevent people from accessing the mental health services that they need. Because one of the most frustrating barriers that I see in terms of people getting the proper mental health services in terms of access is transportation. People just can't get there. And if you don't suffer from some disability, there's no access to any type of government or state service to get you there. So I think that we're learning a lot. I think that we are also finding out that many things that we thought couldn't be done can be done. Okay. And I think I mentioned this before. I just want to say a little bit about stigma and mental illness in minorities. I think we covered a couple of these before, but it's so important if you're going to combat stigma is to talk about it. It has to be a subject of discussion. It can't be something that you want to keep private, because that just leads more into the isolation. We have to continue to try to educate ourselves and educate others. I go back to B.B. Campbell one more time. That was one of the major things that she spoke out on. She wrote books about stigma. She went out and talked to people about it. She met with the legislators. This is how you get the awareness to the level that you can implement some change. And it's very important that if we increase the amount of compassion that we show to people who have mental health issues. For some reason, people view mental health as different from physical health, but very often the struggles are the same, the consequences are the same. We have to empower people to be able to come out and talk about what their needs are and not be stuck feeling bad about themselves. I'll share with you for one moment about a patient I saw not too long ago. And he was extremely frustrated because he had to take medications. And he felt that he was a strong person, that he was above that. And while he struggled with a bipolar disorder that was well controlled when he was on medication, he just refused to take any medication because he said that every time he took a pill, it made him feel bad about himself. And no one had ever really sat down and talked to him. From the beginning, it had been, oh, you have this condition, you need a pill. And that's what we need to change, that we have to educate people not only about their disease, but the treatment options available to them that don't include medication. That's one thing that's happened in the mental health field, is that people are driven towards immediate results. They don't recognize that these things progress over years, and it takes time to reach a place of stability and recovery. And one of the things that we have to do is educate them about the process involved in this. And the comprehensive treatment is the most important thing in terms of reaching a period of recovery from a mental health condition. And it's not just going to magically happen with a pill, because a lot of these things stem from childhood trauma. In the mental health field, over the last several years, we've seen that the role of trauma plays in many of the mental health conditions. And without addressing that primary issue, you can't stabilize the issues that they have in terms of depression and anxiety. And we need to continue to encourage more of an equality between both the physical side and the mental side of illness in this country. All right, Kyle, next up. Discrimination in minority mental health. It comes in all kinds of different ways. Somebody once taught me that stigma is when you look at something different, but discrimination is when you treat everybody different because of who they are, where they're from, how they speak, how they look. And in the society that we live in, we can't deny that is still a barrier to people getting proper mental health care. I know as we looked at LGBTQ, they're more likely to be discriminated in terms of getting access to care, that they very often can't even get an appointment. Just developing a network of providers is one of the things that we have to do in terms of combating the discrimination that we see within health. And once again, it ties back again to stigma. And the other thing that people need to know is what their rights are. When they go to a place, or they can't get a service, or they get an appointment that's, we can see you in 6 months from now or 7 months from now. Most of these places have policies and requirements. For example, I know that many of the health insurance plans, in terms of their quality control, when a person is discharged from a hospital, one of the things that they measure is whether they have a follow-up appointment with an outpatient provider in the next 10 to 14 days. But if you can't get that appointment, then you need to be calling back to that health plan and letting them know that you need help in finding that provider. We run into discrimination from everything from the way people look to the way they speak, and that one of the things that we're going to have to do in terms of addressing this whole issue is the diversification of the workforce. The more people are like me, the more comfortable they are in coming to see me, talk to me. And we need to look at how we can diversify the workforce to meet the needs of the people that need to be served. Okay. And then I just wanted to talk a little bit about education. Kyle, can you bring up the next one for me? And this is just some mental health facts that I think are important that we know. It ties back to that whole theme of we're not alone, that there are millions of people out there suffering, that there are millions of people struggling with mental health conditions. Just from a statistical standpoint, 1 in 5 adults experience some type of mental illness. One half of all chronic mental illness begins by the age of 14, and 3/4 by the age of 24. And I think that one of the most positive things that I've seen happening in the field of mental health is the attempts to work with teens and young adults that experience the first onset of a mental health condition. And what we've learned is that by educating families and community and teachers that help them identify symptoms, raise concerns, be open in terms of when they see something, helping people get help. This is one of the best things that you can do in terms of producing a significant outcome for a person. You know, one of the things that we look at is, and I'll use schizophrenia for an example. When a person is diagnosed with schizophrenia, if we go back to the whole issue of stigma and history and all those things, in my community, the first thing I always used to hear is, well, I guess they're going to get a check. You know, it's like, okay, you got this diagnosis and all right, it's all over for you. You're on a disability now. It takes you out of the regular workforce, the community. Somehow people look at you all differently. And I think the last statistics I saw, approximately 15% of schizophrenics are employed right now in the country. But with the onset of therapies, medications that we have, there are more medications for schizophrenia now than at any other time. And with the proper community support, stabilization of symptoms, there's no reason individuals can't be rejoining the workforce, you know? But we have to get people's minds open to that, to seeing people not as their disorder, but as people that have a condition that's now treatable. Let's look at a couple other numbers, Kyle. And this is just prevalence of mental illness by adults. 2.4 million people with schizophrenia is a lot, even though it's only 1.1%. But those are a lot of lives, a lot of families' lives that are impacted by this. And I think one of the things that we need to do is by increasing the resources, increasing the access to proper care, that we can help these people have a much better recovery and really more opportunities for more improvement in the quality of life they lead. You know, one of the things that I see very often is working with people who suffer from psychotic disorders is somewhere along the path they've received this message that the only place that they're ever going to be is in some group home or some boarding home, that, you know, that their lives are virtually over. And that leads to more substance abuse, more risk of suicide, but that doesn't have to be that way. And it's only by information, awareness, access, that we can get these people the help they need and reach the productivity that they're capable of. And then this is just a couple of things emphasizing just the prevalence of depression and anxiety disorders in the United States. I think we got one more informational slide, Kyle. And this just talks a little bit about the impact of and consequences when these issues aren't addressed. The prevalence of co-occurring addiction, homelessness, corrections, you know, all these unaddressed issues come out in the system at some other place other than where they have to. You know, and I'll mention this as we start kind of winding up, though, is just in the correctional setting. We talk about criminal justice reform, and then we look at all the number of people who were suddenly, when COVID hit, released and from different jails and correctional departments because of concerns of spreading the virus in there. Well, those same resources could be used when there's not a pandemic to provide to people to get access to proper mental health conditions. Because what we see a lot of times is that these people are really incarcerated over very minor things that don't require that level of restriction that could be dealt with in other ways. All right, next slide. And this just once again talks about the people in need and the lack of service. 60% of adults with a mental illness did not receive a service in the previous year. 50% of age 8 to 15 did not receive a service. And then we look at African American, Hispanics, that the rate of access to service is 1/3 the rate of us. All right, and just once again, our time is short and I want to leave some questions if people wanted to, but I just wanted to emphasize, we talked about early intervention, and that's getting to people quickly whenever the symptoms come up, technology, the use of best practices, and then focus on patient-centered outcomes. And let's kind of scroll through these and I'll give some examples of them, Cal. Early intervention. And that's just recognizing the signs of a mental illness or condition before it gets worse. You know, very often we see friends and family with things that we can't quite put our finger on, that we see changes in their behavior, or they become more isolated, but we don't want to say anything. This goes back to this whole idea about communication, talking to people, because the one thing that we've learned about mental health conditions is the earlier that we get people involved in treatment, the more successful the outcome is going to be. That what you want to do is get people before they get into this system of feeling hopeless and the frustration that they don't have any other options. And that in terms of the early intervention, the more you deal with a condition, the more stress you have. So the earlier you get there, the less stress you have, and the easier it is for recovery and having a positive impact on a person's prognosis. Okay, and technology. With technology, the main thing that people talk about these days is the telepsychiatry and access and the role of video conferencing in reaching people. But there are more mental health apps now than ever before. You can access case management, you can get information about different therapies, smartphones, cell phones, tablets. There's a whole nother world thanks to technology. And when you're talking about getting access to providers and culturally competent care, very often this might be the outlet that we need to start exploring in terms of accessing those services. Because going back to old terminology, the brick and mortar providers, that's not growing fast enough. That's not getting out there fast enough to get the people what they need. So what we're gonna have to do is be more creative in our thinking, in the way that we look at accessing services and producing what we want in terms of these more positive outcomes for people. All right, and this was just a little bit about the apps and some of the things that people like about them. And patient-centered mental health care. I did want to really say something about this because this is, my emphasis on this is that this is a team approach. That in terms of producing good outcomes, the days of I'm the doctor and you're the patient, you need to do what I say, is gone. If we want to really have successful outcomes with patients, what we need to do is keep them actively engaged in their own care. That there needs to be the therapeutic relationship between the provider and the person receiving the services. And the focus needs in terms of improving the outcomes is helping a person recognize their own strength and taking those things that they have potential for and then helping them in developing that strength. And the more we treat people with compassion, dignity, and respect, that is the main way to fight stigma. Because once again, I just want to, stigma is bad because it works on two ways. It comes from the outside and it comes from the inside. And both ways can impact a person and prevent them from getting the care that they need. And we also need to just continue to promote a recovery model in terms of mental health conditions. I think we've gotten comfortable in talking about recovery and substance abuse, and we need to be equally talking about it when we talk about different mental health conditions. All right, and best practices. Best practices just means getting out there and doing what's going to help a person identify what they need and get them into the proper care. We need to make sure that we're providing people with with proper screenings. And going back to one of the things that we had said about meeting a person where they are, one of the things that we've been able to do in the Department of Mental Health is partner with churches. And what we found is that when we look at these congregations that provide supportive services, they're not there to provide treatment to people, but what they do is increase awareness, support, and what they do from our partnerships is help get them into treatment. It helps battle the stigma, because one of the things in certain communities is that they go to the church before they go to the mental health provider. And then what we need to do is bridge that by partnering with each other to get them not only the spiritual support that they need, but also the support from them for their mental health condition that gets them into a recovery. And then we also just need to make sure that the things that we do aren't all just academically studied, but that they've been proven clinically to work, and that we've seen them work over and over in different communities, and also in different communities of color as well. All right, and I think I talked a lot about COVID-19 already, and I just wanted to say that while it was a double blow in terms of access to service, I think it's opened the door in terms of creative thinking and ways of opening up new mechanisms and avenues to get people to mental health services. And I will close with a B.B. Moore Campbell, since I'm a B.B. Moore Campbell fan. And it's just a quote she made about, once my loved ones accepted the diagnosis, the healing began in the entire family, but it took too long. And I think that's the thing that strikes me, is that we need to destigmatize mental illness and work towards getting people into the help they need. And I will be quiet then in case we have one or two questions.
Hey, Dr. Burley, thank you so much for your presentation. And perhaps one question is really all the time that we have at this juncture. What Dr. Burley has agreed to is sharing his contact information. So if you have any questions for Dr. Burley from this presentation, please reach out to him at Howard, HOWARD Burley, BURLEY @tn.gov. And for all of you chiming in on Zoom, I'm going to put that into the chat so that you can put your follow questions. And we also try to address those as best as we can from the ones that we have on Facebook and on Zoom. And so Dr. Burley and I will touch base then. The question that I wanted to ask has to do with this idea of stigma and this idea of language. And as a doctor, as someone working with clients, sometimes even with some minority populations and communities, the word mental health or these other words that sound kind of scientific and clinical don't show up in the cultural conversation. They don't show up in the language that these communities are using. So what are some ways that we can shift our language a bit to be a little bit, to talk to these communities, to be so that they're hearing what we're saying rather than something else?
Well, I think when we throw out the word mental health, people look at it as like, I guess, trying to define who they are. I think as we talk to different groups, what we need to do is focus on what the issue is they're struggling with. maybe instead of talking about mental health, we don't have to give people a diagnosis to get them help. What we can do is talk to them. If you're not feeling emotionally well, there are things that can be done to help you. If you're having symptoms that are coming out where you don't feel like doing the things that you used to, or you don't have the energy to do those things, that there's a way to talk to them about talking about a health professional, because sometimes what you need is somebody to distinguish whether this is a physical or whether it's a symptom of some other mental health condition. But I think what we need to do is talk to people about what they're feeling and what they're experiencing, because that's something that everybody can identify with. That we're very often too quick to try to put a label or a handle on a certain thing, and just try to let people know that we're interested in letting them have the best quality of life they can, and just what they need to do to get there.
Wonderful. Well, I think that was well said. And thank you so much, Dr. Burley, for your time and for your presentation and lending your expertise with us. And so on behalf of my colleagues at NAMI and for so many other folks that were involved in putting this series together, I want to say thank you to you and to, yeah, this the lovely conversation that we were able to have, and it was cut short, and we'll have to continue it through the next couple of series presentations.
Well, hopefully it'll lay the groundwork and we'll just move forward from here.
Absolutely. So please tune in next Wednesday at 6 p.m. Central for the next webinars in our series, as well as looking out on our YouTube channel. We're going to be putting the recording of this presentation and our upcoming presentations there for you to view on demand. And with all of that, I want to thank you all for being here, and I hope you all have a great rest of your Wednesday. Take care.
All right. Take care, everyone.